My name is Shah. I'm a radiation oncologist at the Cleveland Clinic. I serve as the Director of Breast Radiation Oncology, as well as the Director of Clinical Research in Radiation Oncology. Management of the axilla has drastically changed. For decades, women who had positive sentinel lymph nodes underwent completion axillary dissections. However, over the past few years, we've seen an evolution in that thinking, with the axillary lymph node dissection being replaced with axillary radiation or no axillary radiation. In women undergoing breast-conserving surgery, two trials have evaluated this proposition. The ACOSOG Z11 trial included women who were clinically T1 to 2 with clinical node negative disease and were randomized to axillary dissection or radiation therapy following surgery. Of note, while radiation therapy was not meant to be targeted to the lymph nodes with additional fields of radiation, a subsequent analysis of the study showed roughly 15% of patients received regional lymph node radiation and approximately 50% received high tangents covering a lower part of the axilla. The study was underpowered and failed to meet its accrual goals, but did not demonstrate a difference between axillary dissection and no axillary dissection in this patient population. The AMAROS trial looked at women in a similar situation, but randomized patients to axillary lymph node dissection versus axillary radiation. While over 4,000 patients were enrolled, only roughly 1,500 had positive lymph nodes and therefore were included in the randomization. Recently, 10-year outcomes from the study were presented, demonstrating no difference in outcomes long-term. Additionally, axillary radiation was associated with reduced rates of lymphedema as compared to axillary dissection. What these data suggest is that patients undergoing breast-conserving surgery who are clinically node negative prior to surgery, that when a sentinel lymph node is involved, that axillary dissection can be excluded in patients who do not have gross extracapsular extension or more than 3 lymph nodes involved. The role of axillary radiation versus standard radiation still remains to be seen, as studies were differing in their approaches with respect to this. Another major question is how these studies can be extrapolated to the mastectomy setting. Guidelines do allow for the extrapolation of these studies to the mastectomy setting, and in theory, axillary management should be independent of whether a patient undergoes lumpectomy or mastectomy. As such, in my practice, I feel comfortable extrapolating from these trials and offering axillary radiation as compared to axillary dissection in patients with positive sentinel lymph nodes who are otherwise clinically node negative and meet other trial criteria.